Now we'll request one of the most successful program which has happened in the country through LVPEI approach, and we'd like to know what was their initiation, how they achieved these goals, and what are their future goals to achieve this primary health care in the community.
Good morning, everyone.
Dr. Khanna.
Good to see a couple of people in the morning session, 8 o'clock for this session. So on behalf of Dr. Rao could not make it, so I'm just trying to, it's difficult to get into his shoes, but still I will try my best to give you a brief overview of the community ophthalmology model for LV Prasad Institute. And this is the approach. So if you look at overall India, I think we have done a significant amount of work. I think it's the efforts of each and everyone sitting in this room and not also in this room, which led to the reduction in prevalence of blindness from 1.4 in 1976 to 0.36, which is now. But still the absolute numbers are not going down because the population, that time 1976, the population was 40-50 million, but now the population is 1.5 billion. So even if despite all our efforts, though the prevalence is going down, the absolute numbers are not going down. So we have to have some different kind of approach if you want to reduce the absolute numbers also. We also looked at what's the cost of blindness at the national level, and the overall cost of blindness is almost $54 billion, which is 0.6% of GDP, which is a huge amount. This paper was published 2-3 years back in IGO. And what Dr. Sethi pointed out, the number of challenges, I think everybody faces these challenges. So I won't go into details of these challenges, but basically it's like human resource, quality, infrastructure, technology and all that. So how do we leverage whatever we have? So challenges will be there. So how do we leverage what we have to better give the optimum services? So coming to this, I'm just give you a brief overview of LV Prasad Institute model. So we don't have a CAM-based approach. I think most of the country follow CAM-based approach, but we go to the community and put permanent facility. So because of that, we have now, we are located in 3 states and almost to some extent in Karnataka at 308 locations through primary and secondary and tertiary care. So this is one of the largest eye care network in the world, and also I think I don't see, we were looking at healthcare network, I don't see any healthcare network also having this kind of spread across different states. The entire system is built on 10 functional arms, has 10 functional arms and 5 core values. I think we make sure that there is no compromise on these 5 core values whenever you look at any programs. Coming to this, the entire model was built on, the foundation was based on the Andhra Pradesh eye disease study, which was a seminal population-based study which we did almost nearly 3 decades back. And this entire health pyramid was based on that, and we have at the bottom of pyramid a Vision Health Guardian, which takes care of eye care of 5,000 population. At the second level, we have a primary eye care center, where we have a high school trained graduate for 1 year to do refraction, referral, dispensing of glasses, as well as rapport with the community, and also do teleophthalmology and other technologies. So this is typically a vision center, what you see in an outpatient department of any ophthalmologist actually, which is like a slit lamp, applanation tonometry, fundoscopy, dispensing of glasses, and teleophthalmology. So this is typically what they do, and they have a app in which you collect the entire data is stored. After when we were looking at this vision center long back, what we found was like they are picking up all the conditions what an ophthalmologist will pick up. They were able to pick up cataract, corneal conditions, refractive error and all that. What they were missing was glaucoma and retinal pathologies. That means all the posterior segment conditions were missed. So almost 2/3 of the 2/3 to 1/4 of the 3/4 of the posterior segment conditions were missed. So how do we make sure that they pick up? Because when we go to camp also we miss all these things. So and in the vision center also they are able to pick up, but not to the extent what an ophthalmologist will pick. So how do we improve that? So based on that, we designed a study which is called LV Prasad Glaucoma Epidemiological Molecular Genetic Study, which is called GLEAMS. And what GLEAMS found out was non-mediatic fundus camera and FDT will improve the sensitivity of picking up glaucoma and other posterior segment conditions. But when we looked at the cost effectiveness, non-mediatic fundus camera was much superior compared to FDT. So that is the reason we had, it was not based on somebody's whims and fancies that put a camera there. It was based on hardcore evidence, this was a PhD work of 2 students, which came out that using a non-mediatic fundus camera will improve the sensitivity to not to 100%, but 70 to 75%. It's not still reaching 100%. Based on that, we designed a new generation vision center, which is called futuristic vision center, in which incorporated fundus camera and also a ohm perimeter, which does the visual fields. And this is what was the difference we found, that in conventional vision center, what was showed in the previous part, they were able to pick up now all the posterior segment conditions, they were able to pick up many other anterior segment conditions and all, and travel time of the patient was reduced. So care was being provided at the doorstep. So one thing which is different from camp was like people can access this care anytime they want, anywhere they want. So we were closer to the community that way. In terms of now coming to the camp approach, so we were looking, there were multiple approaches. Now we can debate that camp is much better than these people. I can see 100 patients in a camp, I can operate 50 in one go, you operate 10 only in one go. So we looked at different models. A camp approach is one is door-to-door screening. People do door-to-door screening, Universal Eye Health, which Operation Eyesight is doing, and other partners are also doing, where they pick up people from door to door. The third was school-based screening, and fourth was a vision center model. So we looked at whether what is good in long run. So we looked at all the data of all this from 6 partner hospitals. It is not from only one hospital, but it was from different partners. We took 6 partner hospital data, and what we found was, in short term, the red dotted line what you see is, in short term the camp approach are very good. You will pick up immediately, the returns are very good. But the can I have a pointer here? It's not a pointer, you can use mouse. If you look at this blue line is a vision center line. This is the most sustained effort over a period of time. If you want, you can do camp once in a while, then you go after 2-3 months, do one camp, you go after 3 months, do one camp, then there is a break, summer comes, you don't do a camp. So when we looked at the entire thing, what we found that in terms of long term, say more than a decade, the vision center approach are the most cost effective approach in terms of the returns for investment actually. In terms of the number of patients seen, school screening is also good, door-to-door screening is okay, but it's a slow process. But in terms of cost effectiveness, the vision center approach is the best in terms of long-term investment. So this was published in the Lancet Regional Southeast Asia Journal. So these are some of the numbers. I won't go into details of this number. So in a day, we see almost like 6,000 to 7,000 outpatients across the network, and of which almost nearly 25% are seen in the primary eye care network. Coming to the third level, where is like service center, where we have, and these are almost we have 24 service centers at this point in time. This is the place where ophthalmologist is there. So ophthalmologists don't go to the camps, but we bring, these patients are transported from vision center to the secondary center, where they provide all the kind of care what a regular ophthalmologist will do. So we have he is supported by an eye care team of 25 to 30 people, and these are the number of surgeries they perform over a period of time. And in terms of financial sustainability, they are almost like break even in terms of income and expenditure by doing 70% services free of cost. Now coming to next level of what we did was, next level is using the teleophthalmology across the network. So this is what we use, teleophthalmology across the network, where we are able to pick up all these conditions. So these patients need not travel. So using teleophthalmology, we are able to pick up all the anterior segment and most of the posterior segment conditions also, and so that patients don't have to travel to long distance for care. And also we make sure that people who are emergency, when you go into camp, you don't know what is emergency, what is non-emergency, but we make sure that whatever are red, our emergency are taken care immediately there and then. So we make sure that emergencies are transported faster. We use some of the innovative device from our centers, and then also there is a real-time ROP my colleague Tapas is doing in Bhubaneswar center. In terms of providing specialty care, now in the camps we don't provide specialty care. So what happens is, now our specialists go to the secondary care center and provide specialty care there. At the same time, what we found that corneal transplant is also being done there. What we found that follow-up care is much better at the secondary care. The compliance to treatment is much better when you do a transplant at the doorstep rather than doing at a tertiary care center. These are some of the retina services which we do. So what we do is, when the retina people are going, we have a van which has the diagnostic equipment. So they will also go to the center on the same day. The retina faculty is there, and all the investigations, OCT, V-scan, fundus photos, everything is done there and then itself. And the treatment, 90% of treatment are given there. Those who require surgery are asked to go to the higher level of care. Also, we have a home care model where we are going to home of people who are disabled. These people also will not come to your camp, because These are disabled, these are not able to walk also. So we are trying to provide home care at the doorstep. This is one of the concept paper which we publish. I won't go into the video of the home care in the interest of time. But overall, if you see what we have done, so if this center is a center which is located in one of the most remote rural areas in Adilabad, which is called Mudhol. I think Vaibhav knows about it. So what we have done, putting this center almost like more than 25-30 years, what we have seen that significant reduction in prevalence of blindness because we were there permanently available and people can access care, we afford care and we are available for them whenever they want. Another example of vision center giving universal eye health, when we developed vision centers, this is example of 7 vision centers we had in around Mudhol. What we saw in 10 years, vision center has covered almost 45% of the population. So almost half of the population have access care, and now we are doing a model where we are trying to see that how do we cover each and every person in that house of a vision center coverage area. With this, I would like to end, and thanks to my entire team. I think these are all efforts of my entire team who is working on the ground day in, day out. Even when I am here, they are on the ground there. Thank you very much. Yeah, but
Yeah, you can come to the mic there.
How much do you think the role of the EMR and how has that improved your outreach activity?
yeah, so EMR once is like at the visions, we have EMR at the community level also. When we do door-to-door screening, we have EMR. So when you say EMR, when they say refer, immediately the alert will go to a vision center. Vision center will know these are the people who are referred. So they will call these people to come and access care at the vision center. The same alert will go to secondary center also. And the second thing EMR is done is at the vision center level when we do EMR. So they have a tele-ophthalmology system where they say referral. It's an emergency, immediately it's put as red. The doctor sitting in the command center will immediately get alerted. This is emergency referral, immediately has to be taken care. The alert goes to secondary center also. So people will call and make sure that this is an infection, this is an injury. It has to be immediately transported to the next level of care. What we have found that people who come, injury patients, if they come within 48 hours, the chances of recovery is much better than compared to when they come after 48 hours. So that paper we published again in Lancet Regional Southeast Asia. That is one thing. And then there are yellow referrals, and 90% of referrals are taken care. Suppose they were referring in the past, now say infections or say allergic conjunctivitis, the treatment is given by doctors through teleophthalmology itself. The third thing is EMR is done when I see as a specialist you go to a tertiary secondary care center, you advise a surgery, immediately you can book a surgery. The patient doesn't have to travel again to tertiary center, again go through the same process of check-in, examination and all. Directly surgery is booked by the consultant at the secondary care, so patient can directly go for surgery. On the day of surgery, he can reach and get the surgery done and go back. And the follow-up care again can be done at the secondary care level itself.
Okay, thank you so much. Acha, we have one question. Ash.
I've seen a lot of self-screening and follow-up that is done by the patient itself. It doesn't come under any of these categories that you show. So how much of follow-up actually actively happens is that as a percentage in your entire
follow-up if you are at the doorstep, follow-up in the secondary care is almost 85 to 90% for people come for follow-up for their cataract surgery or say keratoplasty, I could say. Just giving example of keratoplasty, we have almost 85 to 90% 1 year follow-up rate. The published paper we published in BGO, we found that people who were operated in tertiary center at the same time, the follow-up rate was only 25-30% compared to in secondary care it was 80 to 90%. Because we are at the doorstep, they know where they have to go, but at tertiary center they come from far off. They get lost. So what we say, most of them might we also send them to our alumni group is there. We tell them you go and follow up there, but we don't know how many of them have gone to alumni. So right now we are going to track them, like what happens to each one of them. Self-testing, there are apps coming up. WHO Eyes have come with an app. We have written that paper on WHO Eyes app, how sensitive and all that it is. It's a very good app. And now Infosys is coming with an app called Site Connect. I think we are working with that. It's very primitive to present the data at this point in time. WHO Eyes paper recently, just now we have sent to BGO. And once we have that data and once we have, that was just testing of the app. So right now that app has been tested. Now we are testing the Infosys app. And if that app works, probably we'll roll it out to the population also. Thank you. Yeah, Ashi.
There's this one question that has always been in my mind. I wanted to ask Dr. G. N. Rao. You are there, so you please tell us. That was
you can
about
call.
why we are not, why do you think scientifically camps are not the way to go?
because you are camps, you can do a camp and then operate and leave them, and then follow-up care is not. You may go for a 1 month follow-up, but what happens after 3 months? He develops a CME or he develops a detachment. Where does he go?
So
90% of them will not have anything, but what happened to the 10%? They need to go somewhere. Then if you are there, they know that this hospital is there where I was operated, they can go there, follow-up care. You have to close the loop, Ashi. Unless you close the loop, you have done the intervention, but loop is not closed. You have taken the responsibility for their lifelong eye care actually.
So is it completely irrelevant now?
Camp approach is like, I am not saying irrelevant, because there are like, everybody can't have a secondary care or a vision center, but these are the models which you can emulate over a period of time. In the future, I think that's the way to go. Instead of having camp approach, I think everybody is behind vision center now. There are so many vision center which has come up. When we built the first vision center, I won't tell the funding agency, but they said this will not work. Just throw it off. They didn't fund even also. We got from some other funding agency to vision center, and now I think look at the data now, the entire world is behind vision center. The donor come to you and tell that, please, are you developing vision center, building vision center, take the money from me. Yeah, Ashi will tell you. Don't the donor come to you and tell that how many you develop a vision centers now? Yeah, they come to you. Yeah, if you want, we can connect you with the donors and they can come and.
Yeah, thank you so much. Yeah. I think, Ashi, you asked for a, camp approach. I think there is a need for a modifying approach for a camps also. It can be a very good tool for, patient education, awareness, screening, if not surgery. Surgery may not be applicable, but other way around, we can use this camp approach, and it has been a very successful model in the past. Now we understand the information technology, the telemedicine has made things simpler, but to have people together in one area physically and somebody speaking to them will make a huge difference. I think we need to sit down and reform this, our camp approach in a different way. You have a very good point there.